Rahim. Assalamu alaikum everyone. Alright, it is very good to practice random ECGs because when you try to practice random ECGs, it becomes more easier for you to get the finding on the real ECGs that you will get in your exams. Because on the even on the YouTube and on various sites you can find the ECGs which are already labeled, and you are unable to practice the unlabeled ECGs and random ECGs. Like if you want to study for the left bundle branch block, you just write down and you get the ECGs of left bundle branch blocks, but at that time you already know that it's a case of LBB. Then you cannot actually generate those real signals in your mind that will help you in the real life to get the proper diagnosis. So whenever I upload the ECG, and as I have told you that we will be practicing random ECGs, just pause the video once and try to comment on that ECG yourself, and then proceed for the findings. So in this very first ECG, as I have told you, that we first of all look for the rhythm. So the rhythm is here we can find the P waves, and in the lead 2, so this is a sinus rhythm, and then calculating the rate, we divide 300 by number of boxes that is present between the two RR waves, which is approximately 60 to 70 beats per minute. As I have already told you that it is better to tell a range than to quote a single figure. And then we come towards the axis. Both lead 1 and AVF are upwards. This is a normal axis. Then we start looking at the PR interval and QRS complex and the T waves and the ST segment. So here we can see that very evident the PR interval is very much prolonged in all the leads. So this is there is prolongation of the PR interval. Normally PR interval you can just find the one big box. Like in here you can see you are finding 2.5 big boxes between the PR complexes or the PR waves. And then we start looking at the T waves and the ST segment in elevation or depression. So here look, in the lead V1 we have T wave inversion in V1, V2 and V3, while it's normal in lead V4, V5 and V6. So what is the complete assessment of the ECG? This is first degree block, and we have most probably this is when we getting it with the T wave inversion, this is non-STEMI. So if I ask you that what would be the treatment of this patient, will you thrombolize? The answer is no, we don't thrombolize in non-STEMI, but the standard treatment that is given for the ischemic heart disease or acute coronary syndrome, not exactly ischemic heart disease, for acute coronary syndrome, as it consists of 3 parts, and STEMI, and stable angina. So in case of non-STEMI, we have to give heparin, we have to give aspirin, we have to give clopidogrel, a beta blocker, possibly, because here we are getting a first degree block, so we have to be very careful. But is there indication of and then a statin as well? So we have to be cautious while using beta blocker in this case. So can you use is there any indication of pacing in this situation? The answer is that if in the first degree block we treat the underlying cause, and then we are able to arrest the further progression of the block, and we don't actually insert the pacemakers for first degree heart block, but you never know, if the patient is vitally unstable, then the decisions really become different and the scenario becomes different, that how would we treat this patient. Alright, in this second ECG, looking at the rhythm or commenting on the rhythm, we are unable to find a proper P wave if we even see in the lead 2, and which is the actual lead in which we look for the P wave. But the thing is that if you see that the rhythm is before commenting on the rhythm, if we just look that it is not irregular, that is very evident. And one very important thing that we can see in the ECGs is is the ST segment elevation. And you can see that even these are not the flutter waves and these are not the fibrils. So we can and the rhythm is not irregular. So most of the time when you like are unable to find the other things, you have to comment like this, that the sinus this is a sinus rhythm most probably. And this otherwise it does not fit into any other rhythm in the present situation. So it's not a rule, but a general concept that I want that you should know. Sometimes it is difficult to find the P wave, but still the rhythm is considered to be sinus if you are unable to fit it in any other rhythm. Then commenting on the axis is normal. Both lead 1 and AVF are upwards. Axis is normal. After axis, we calculate the rate. We count the a number of large boxes between the two R waves, and the rate is in between 30 to 40. And then we start commenting on the PR intervals and the QRS complex and the T waves and the ST segment. So one thing that is very evident, the lead 1 we cannot find a significant change, but if we look at the lead 2, there are Q waves. First downward deflection is a Q wave, so we can find the Q waves with ST segment elevation in lead 2. And we cannot comment on the T waves over here. Then here again in the lead, if as I have told you, the lead 2, 3, AVF are the inferior leads. So it's they actually the changes on the ECG, if it is following a vascular pattern, you will find the changes in all the inferior leads, that is lead 2, 3 and AVF. So there are Q waves and ST segment elevation. Then looking at the AVR and the AVL, you can see that there is downward sloping of the ST segment in lead AVL. And what else we can see? We can see that there is ST segment depression again in the V2, and V3 is normal. And in the V4, V5 and V6 again we can appreciate a little bit of ST segment elevation, but the ST segment elevation is very evident in the inferior leads that are leads 2, 3 and AVF. So in context, if the patient is having chest pain, this will be labeled as acute inferior STEMI. And obviously if I ask you the treatment, you have to after controlling the pain of the patient and in the absence of any contraindication, the patient should be given aspirin immediately, and then the percutaneous coronary intervention, PCI or thrombolysis as soon as possible in this case. In this third ECG, this is a very simple ECG, and even if you are just finding this rhythm on the monitors that are attached to the patient, you can easily comment that you are able to find broad complex tachycardia in this case. And then further, you cannot comment on the P waves, you cannot comment on the ST segment. The one important thing about ventricular tachycardia, that broad complex tachycardia is ventricular tachycardia until unless proven otherwise. And when the patient comes to you with ventricular tachycardia and the patient in case of severe circulatory failure needs immediate DC cardioversion. And one important thing that I want to tell you, that why it is VT, it is not Torsad D point, is because in the VT you can see all the QRS complexes are regular and all are pointing upwards, and while in the same lead, while in case of Torsad D pointers in the same lead, a few points will be upwards and the other points will be downwards, and then you label the case as Torsad D pointes, like it is the movement of the points. And while in case of VT, you can find only the like they all are either upwards or they all are either downwards. You cannot find a half of the QRS complexes facing upwards and the others facing downwards. In that case, it would be labeled as Torsad D pointes, and we have to treat the Torsad D pointes also. As I have told you, the drug of choice is Maxalfate in that case, but because we have to be very cautious and have to treat Torsad D pointes, because it can convert into the ventricular tachycardia, which is more lethal and fatal to the patient. So this is a broad complex tachycardia. Whenever you see this kind of ECG, this is ventricular tachycardia. In this last ECG, Commenting on the rhythm, you are able to find the P wave. So this is a sinus rhythm. Both lead, and after counting the number of boxes between the two R waves, you can get to know that the rate is between 40 to 50 beats per minute. Both lead one and AVF are upward, so the axis is normal. Again, you start looking at the QRS complexes, ST segment, and the T waves. After looking over here, what you can find is that like there is a normal progression of the R wave in the lead V2 and V4. You can see that there is no R waves, and all of a sudden a very large R wave appears in V5. So whenever you find this kind of thing, that there is absence or very small R wave from lead V2 to V4, and there's sudden appearance of a normal R wave in lead 5, this is termed to be poor R wave progression. And despite the absence of the Q waves, this probably indicates an old anterior wall infarction. As I have told you, the lead V1, V2, V3, V4, these are interoceptal leads. So whenever we are finding this kind of thing, poor R wave progression, we can comment on the ECG in a way that either this is old anterior myocardial infarction, or it can be, what could be the other explanation for this? It can be due to poor lead positioning. So what should we do in this case? We can repeat the ECG, and in order to ensure that the chest leads have been placed properly. And we can also proceed for the echocardiogram or chest x-ray of this patient to see that if left ventricular impairment is responsible for the changes or the symptoms of the patient with which the patient presents. Thank you so very much.